So again, it's my pleasure to welcome everybody to our outstanding webinar today. Very excited for the lower extremity decompression in diabetic patients webinar. And we have, as I mentioned, just an outstanding panel that it's my pleasure to introduce today. Starting with Dr. Tusheva, who is a resident and a member of Dr. Pejkova's team in North Macedonia. She has led and assisted in multiple publications on the use of the Dellon decompression technique, has co-founded the Macedonia Association for Reconstructive Microsurgery. Her research interests span peripheral nerve repair and regenerative techniques, and she's presented at numerous international conferences. And as we were just discussing, she'll be presenting at ASPN in January. So if any of you are going to be at that conference, I highly recommend seeing her presentation on Saturday. Next, we have Dr. Pejkova, who is an assistant professor in plastic and reconstructive surgery. She's the president of the Macedonian Association of Reconstructive Microsurgery. She is a specialist in hand surgery, peripheral nerve surgery, microsurgery, and other reconstructive surgical techniques. She leads the structured training in reconstructive microsurgery for students and residents. If any of you follow her on social media, of LinkedIn or Instagram, you will see all of the educational sessions and courses that they put together. Her research focuses on regenerative potential of platelet-rich plasma and chronic wound healing and peripheral nerve regeneration. And Dr. Pejkova has extensive publications and presentations at international meetings and conferences. And then lastly, certainly not least, it's my pleasure to introduce Dr. Dellon, who is a real pioneer in the field of peripheral nerve surgery. It's a little cliche to say, but somebody who needs no introduction. Dr. Dellon received his MD from Johns Hopkins University before completing his PhD at Utrecht in the Netherlands. He has authored over 500 peer-reviewed publications. He's pioneered multiple techniques, including partial joint deinnervation and the Dellon decompression we'll be talking about today. He has founded multiple institutions and helped to found multiple organizations. We could, go on and on with additional bullet points, but our webinar is only an hour long. So I'm going to just leave it at, we're honored to have all of our speakers here today. And with that, Dr. Dellon, I will turn it over to you.
I think most of you know the natural history of diabetic neuropathy, but I think it's very important to emphasize that this is a progressive and irreversible disease. And this is what typically happens. We still have 90,000 or more amputations. Amazingly enough, every 3.5 minutes, there's another amputation in the United States. So if you have a disease that's progressive and irreversible, you can ask the question, do you really need a randomized control study to prove that an operation or a treatment would work? And I think that just stopping the progression, if you can show you can stop the progression, you've shown that you've done something positive. So I want you to keep this number in mind, the 63, the 61%. Just remember more than 50% of people by 3 years have a repeat amputation, diabetes with neuropathy, and I'll show you some statistics that are different than this. Look at the percentage of people who have problems all throughout their foot and in their opposite foot within 3 years. So I'd like to tell you at the beginning that we have reasons to be optimistic about this problem, and I've been talking about this since 1988. That's a long time ago. And I'd like to tell you the reasons why diabetic nerves are so susceptible to compression. The most important reason is they contain a lot of water. Sugar goes into the cell as glucose and becomes sorbitol, which pulls water into the nerves, which gives endoneurial and peroneural edema. So you have a swollen nerve in a tight place. Next, the diabetes itself metabolically decreases axoplasmic flow. That acts as the first crush from the double crush, which we have shown is something that does exist. And the third reason is that glucose will bind non-enzymatically to collagen. The type 4 collagen in the endoneurium becomes stiffer, which means that the nerve can't slide and move so easily. And I'm going to show you this.
So since you could feel your feet. About a year.
About a year?
Yes.
Let's have your sister touch your right foot, which didn't have surgery yet. See if you can feel that much.
No, I can't feel that.
No. Now let's see what happens when she touches your other foot. You just had that surgery yesterday, right? What
Yes.
happens there?
Yes. Yes.
Okay.
So if you're a surgeon, you immediately want to learn how to do this operation. If you're a neurologist, you think the patient's faking. This is just a placebo effect. The patient doesn't want you to feel bad that your surgery didn't work. So we'll talk a little bit about that. How did it happen that me, as a plastic surgeon and hand surgeon, would get to come up with this idea to do lower extremity nerves? Well, diabetics, non-diabetics, 3% have carpal tunnel syndrome. But diabetics without neuropathy have 15%. And if you have neuropathy, about a third of diabetics have carpal tunnel. So as a hand surgeon, I would see people, I'd operate on their carpal tunnel, they'd get better, and they'd ask me to do their other hand, and I'd say, fine, I'll do your other hand. And one day, a patient actually said to me, you help my hands, can you help my feet? What should the answer to this be? The answer should be no, it's a metabolic disease. You should get special shoes, see a foot and ankle surgeon. But thinking about it, the symptoms of neuropathy are really the same as the symptoms from nerve compression. And if you look in the medical literature, actually there are a lot of nerve entrapments. And in the upper extremity, there are three. And if you put them together, you get a glove. In the lower extremity, if you put together the tibial and the peroneal nerve, you get a stocking. So that means that it is possible for a surgeon to work on someone who's thought to have a stocking and glove peripheral neuropathy and break it down into individual nerve compressions. Now you can go to YouTube and type in Dellon and tickle test, and you'll see somebody laughing just like you saw before. And here's a man early after surgery in the recovery room with his wife tickling his foot. So we call it the Dellon tickle test, and you can watch that and show that to people. So by 1992, I had my first group of patients, and every dot is a single nerve. And you'll see that most of these dots are above this line, so that 80% of the nerves we operated on actually improved. And you can see 1984 to 1991, this is what we came to expect, that if we can operate on these patients early enough before they have ulcers, we can get preservation of toes, prevention of ulcerations, and 2-point discrimination. We began workshops. We had 30 workshops, and we trained about 300 surgeons who did this work in 45 states in the United States to introduce this work. Our last workshop was in 2008. And today, what would be called systematic meta-analysis, we looked at a group of more than 800 patients. This is only through 2007. 85% get pain relief. They get sensory improvement. They had no new ulcers and no new amputations. So this is very suggestive that this is something that's going to work and help people. So I'd like to show you what I think is a high-powered study. We had 38 separate centers, each of which had a surgeon that I had trained, so they were doing the operation the same way. We all used the same outcomes. We had enrolled 800 diabetics in the prospective study, and they were followed for 3 years. And this was published in 2012. I'll just show you these outcomes so you can see what happens and what we can do to a progressive and irreversible disease. You'll hear the actual surgical techniques described in a little while, and I won't do that right now. But all of us using the same techniques for pain. 600, not all diabetics with neuropathy have pain, some just have numbness. But of those with pain, we had a reduction in 6 months from 8 to 2. In terms of sensory recovery, over a period of time, we had improvement in 2-point discrimination. We expected, as I showed you in the beginning, in this progressive and irreversible disease, we would expect 1 out of 6, or about 15%, to have new ulcerations. We found only 0.3% at 3 years had new ulcerations. 57 of our patients had previous ulcers. We expected, as you can see by the red line, and as I showed you at the beginning, more than 60% will have recurrences. Even with intensive foot education, the study shows that you can reduce it, but still have about 40 or 50% of people at 2 years having recurrent ulcerations. We had only 3.8% once we had decompressed their nerve, clearly altering this progressive and irreversible disease. We expected 1 out of 6 over time to have an amputation. We had 0.2% of 800 people followed for 3 years. So I believe I'm showing you that we can reverse or stop this irreversible and progressive disease. You could expect about 3.7% of diabetics to be admitted to the hospital for foot infections and ulcerations. We had just 0.6% admitted to the hospital over a 3-year period of time. By the end of our time in 2008, we had had 22 countries where we had trained people. And today, and I thank Scott for putting together this little thing with the pins, we have 31 countries that are doing this surgery. So we really are global here at the Global Nerve Foundation. And with that, I'd like to thank you for listening to my introductory talk and hoping to help you understand how we got to where we are today. Thank you very much.
Okay, so from this slide we can see the prevalence of diabetes, how is in the moment in the world, and because we are talking about diabetic neuropathy, that you can see that in this moment the prevalence of diabetes is more than 537 million, and the trajectory predicted for 2050 is not just curve, it's rocketing. It's they projected more than 100 million people with diabetes by the International Diabetic Foundation. We must have in mind that diabetic neuropathy affects 50% of patients with long-standing diabetes, and the most important thing that we can keep on our mind is that diabetic neuropathy is the most common cause of development of diabetic foot ulcers. So the complications of diabetes are huge. There is one circle, one chain, and they are going one by one because we have angiopathy, because of the microvascular changes, a hypoxic environment, reduced nitric oxide. After that, there is development of neuropathy, vascular impairment. There is ischemia, which is occurring in this cascade, which it is after that followed by vascular impairment and delayed angiogenesis. And we have proprioceptive deficits, chronic inflammation in the patients, and impaired tissue regeneration. All these parts of the chain are going one by one, and we must broke the parts of this chain to prevent the most unfavorable outcome, amputation. So let's think about our feet. I present these two different slides. So you can see on the one side is ballerina, and I just like to remind you how important are feet for us humans, because they are privilege for us, because we are standing upright, we are going walking confidently, and there is everything doing unintentionally, because there are a lot of signals going from the feet to the brain and back, but we are doing every day, and we are humans because we are stand upright. And on the other pictures, you can see our patients with one of the patients with diabetic neuropathy and already developed diabetic foot ulcers. I say about this two-shoe patient syndrome, because you can see he has a sneaker normal wear on one feet, and the other is huge clot because he already has developed diabetic foot ulcer, and he has a huge dressing there, and he has impairment already in gait. This is actually young patient. So we must find a way how we can choose, how you can make the final decision how to help and to reverse that complication that can come from the diabetic foot ulcers, because the diabetic foot ulcer open door for the infection, impaired vascularization, and there is a lot of in the world diabetes related lower limb amputation. There is, according statistic, every 20 seconds in the world there is amputation related to diabetes of the lower limb, and that's mean there is a lot of people who are without leg, and the quality of life is impaired. So I will ask, can we reverse diabetic neuropathy of the foot? Dr. Dellon has a lot of pioneering 20 and more years ago papers and techniques, and he to take all the attention of our colleagues and our surgical community, neurological, the colleagues who are dealing with diabetes, how important is to recognize the complication that diabetic neuropathy of lower limb can be devastated. So after so many years of work, Dr. Dellon described his own technique and tarsal tunnel, which is a very important part of the HIMS technique they developed after, because tarsal tunnel actually is a very narrow bony tunnel which is formed by the talus, calcaneus, and medial malleolus. It's a very narrow canal, and there is in this canal is passing posterior tibial nerve, posterior tibial artery, flexor tendons of the muscles, and the concomitant vein of the posterior tibial artery. So, as Dr. Dellon said in his presentation, the nerves in the diabetic neuropathy are swollen, and in this they are expanded, but in this bony tunnel there is no expansion, so there is no place for expanded nerve and neurovascular bundle, and all of them are covered by this flexor retinaculum. So there is one of the causes, because they are compressed, and the whole function of the posterior tibial nerve, who is branching on this point on the medial plantar nerve, lateral plantar nerve, and the medial calcaneal branches, who are very important for giving the sensation of the foot for the proprioception, nocioception. They are important for giving all that signals for the plantar side of the foot. But in the patients with diabetic neuropathy, because of that compression, the foot is silent. And when we are trying to find the side to discriminate is touch or pain, the patients with diabetic neuropathy, they doesn't feel nothing. So here is the technique that Dr. Dellon developed to release the tarsal tunnel at the tarsal tunnel, but there is a release of 4 medial ankle tunnels, and we made here one graphical design how it is working, and this is from our operation. So the first step is the planning the anatomical landmarks, as you can see on this photo. So all the patient has a TNL positive sign, and this is the incision line which is planned for the patient. So this is a short video of how we are doing. It's a little bit fast forward to see, and we are doing with Valant without Esmar, and there is a really bloodless field for operation. So the next step, we have a neurolysis and division of the tibial nerve from the posterior tibial artery. After that, there is a cannulating of the lateral plantar tunnel to release the medial and lateral plantar nerve. The next step is releasing the plantar tunnels is done when the index finger can enters the plantar compartment, and after that we are suturing just the skin, not to have any tethering of the released nerve. And the released nerves looks like here. They are divided from the posterior tibial artery, and the veins who are going with them together in the tarsal tunnel. And this is here is the fibrous membrane, which is very, very hard and from the diabetes. So when we made the first operations, we and my group, we took something to discuss what we have done. So we made yes, we made decompression of the posterior tibial nerve, but at the same time we realized when we made a decompression of the posterior tibial artery nerve, that tibial artery become free, and she was compressed, and this fracture was compressed. So we thought we should measure something that is different before, or that is it different before or after operation. I speak with Dr. Dellon, and we made plan that we should make a Doppler ultrasonography. So we made a Doppler sonography to the patients, but we had get not blood flow, we get blood velocity. And the results from the patients before and after operation on the follow-up points has been better, because they have better blood velocity than before operation. So Dr. Dellon asked me, okay, you have good results from blood velocity from the Doppler ultrasonography, but we need blood flow. Can you measure it? So because we have one dedicated vascular she's our colleague from the Department of Cardiology, and she works peripheral artery diseases. She's just one who is looking all our group of patients. And I discussed with her, and she told me, yes, we can make the extension of the blood flow, and we need the diameter of the posterior tibial artery. And it was very important parameter, because we can see something else from there. So we made this formula, and we calculated, because we need diameter of the tibial artery, so we get results for the blood flow. And on the follow-up points, we get real blood flow that we gain after Dellon decompression. But it was very important because we have that diameter of the posterior tibial artery, and it's actually bigger than before operation and wider, and that is actually result of local sympathectomy that we are made during operation. After that, Dr. Dellon asked me, can you have curves on the Dopplers, or you have numbers? But it will be better if we find a way how to make a 3D imaging that we really have a better perfusion in the feet after decompression. So we decide to make some new method And actually, we have been inspired by this is on on the left side is the myocardial perfusion with tissue perfusion with scintigraphy with 99 technetium MIB. So I asked colleagues from the nuclear medicine, so if you can do this on the myocardial muscle, I explained them our technique for the diabetic about Dellon decompression in diabetic neuropathy, and spoke with colleagues, and she told me, okay, I have made that on the calf in the patients with diabetes, but never on feet. So let's try. So we made it, and you can see on the these scans that there is a big difference on each. There are both legs on the same patient. One is operated, and the perfusion is better. Regarding the non-operated feet, so we prove that in the microcirculation in the feet is getting better in the patients, and all of these patients we made scintigraphy after 1 year after operation, so they have already healed ulcers. So this with this technique we just prove that Dellon decompression of the posterior tibial nerve is a sustainable technique who just not improve sensibility of the feet, but is giving another very important point to the feet, that we have a better perfusion, although all the patients are diabetics. So we went further, we published our results, we published in JAPRAS. This was the very first results when we have patients on the 9-month follow-up. So you can see we have Michigan Neuropathy Score Index in all patients. So you can see that there is a significant improvement. TNL, which is very important for selection, is getting down from 7 to 2. We have restored a significant improvement across all plantar nerve branches, and improvement of blood flow. Because this was a 9-month follow-up, we have in the 55% fully healed ulcers, and 45% reduced by 83% of the patients. We have very important that no occurrence of new ulcers. So our next publication was to search all the methods were for assessment of the tissue perfusion after Dellon decompression, and there are many. There are you can see Doppler ultrasound, SPY technique, but with technetium that we introduces perfusion scintigraphy. It is for the first time gave these results of the patients who are operated with technique of Dr. Dellon. So this is a perfusion scan of the patient with technetium MIB. You can see improved blood flow in the left operated foot 7 months post-operatively compared to the non-operated foot. We have another publication. We removed tourniquet as a part of original technique of Dr. Dellon, and then use Valant. And it's very important, but because it is more less expensive. We don't rely on anesthesiologists. We can do without anesthesiologists. And we gain bloodless field during operation, and we made this study to see, because in that Dellon technique there is epinephrine, so there are some adverse effects of epinephrine on the patient, because they are with peripheral artery disease, but we don't have any problems with that. You can see in the paper. So maybe it is better because we remove tourniquet. We don't use tourniquet because with that kind we prevent that reperfusion injury which is appearing after removing of tourniquet. And we don't have any wound resistance and any problem with wound healing in the patients. So there are new papers which are on the horizon. We are in the process of publishing of the 99 technetium IBC scintigraphy in after Dellon decompression. So another one is the follow-up the study made at 18 months after operation. So we don't have any recurrences of foot ulcers, and it is another interesting study that is coming is that after Dellon decompression, the patients has improving of foot function. It was actually inspired by a patient who has been operated on and the inclusion criteria was to have a diabetic foot ulcer, but they came back to our office and asked, please doctor, can you operate my other feet? And yes, they are right, because the diabetic neuropathy is not just on the feet where is a diabetic foot ulcer. And I asked him why, and because they are, it's a group of patients who are around 50, and they told me, I like to play basketball because I feel my feet better, which is operated, but the other, although it is without ulcer, I don't feel it there, and that's why we include that kind of patients. So we have another interesting study on horizon. So there you can see here results, how is going in the patients after operation, that there is a healing of the ulcers, and you can see how the skin is much better in the consistency in the appearance after, because we have improved pseudomotor function after operation of our patients. Here is in the process of healing, how it's going, and the whole fit is getting better, and the patients are feel well. But the most important thing is that the patient must have normal glycemic level during whole this process. This was patient who has 12 months persistent ulcer of his feet. He has a history of 12 years of diabetes mellitus. He is a patient on 45 years old, but with he's very precise in regulating of the glycemia, and the results you can see are completely healed ulcer and completely restoration of the sensibility of the feet. Another one patient, this is just 1 month post-op, and I can like to show you how the patient are not more Tusheva, they are wearing ordinary shoes, and they are really have a normal walking a normal life. This was so happy patient. He liked to run here when we make video of him, because he feel yeah, he's running, and the ulcer is healed. This is another patient. You can see he can balance very well, although there is a icy floor, and he's cleaning his yard. It was last year when it was snow here in our country, so they are doing well. this is how the scars are appearing after operation, no wounds, no post-operative infection we saw in the patients. And till now, we don't have in our cohort of patients recurrence of new ulcers. But I must say that till now we have operated on 62 patients, but 4 patients have finished with amputations. Why? Because they think that after operation, after Dellon decompression, we are wizards, we are magicians, that we have solved all the problems. But you know that diabetes is a general systemic disease, and the most important thing is proper maintenance of glycemic control. And because they have poor glycemic control, they have complications as amputations, and we have as a number, but they are not reliable for follow-up. Among remaining 58 patients, we have 24 who reach 18 months follow-up, and they demonstrate complete healing of diabetic foot ulcer, but all of them are with proper maintenance of glycemic control. They have improved food sensibility and sustained improvement in blood flow. This indicated that long-term outcomes are going in the favor when the glycemic control is optimized. So I must say that the decompression of the tarsal tunnels in diabetic neuropathy and diabetic foot ulcer is a transformative tool in therapeutic armamentarium of diabetic neuropathy, because resolve neuropathic symptoms and improves proprioception and sensory recovery. We have improved perfusion through local sympathectomy. We have accelerated healing of diabetic foot ulcer without recurrence of new ulcers, restoration of functional mobility, better quality of life, and most important, all these things are under control of optimal glycemic levels. So you can see the patient, he is king. That is amazing. It is really very encouraging us to go over and to help the patient to back to the normal and to have a normal quality of life. Thank you, Dr. Dellon, for your amazing approach. And this is from our one of the meetings of the ASPN. This is Sofija, Oscar Razman, who I was trained by him, and our colleagues, Dr. Gordana Georgieva, Blagoje Srbov, Dr. Gordana Georgieva, he's also dealing with peripheral nerve surgery, and he has a huge experience in RPNIs in treating of neuropathic pain. Thank you for your attention. That was my it was my honor to share our experience with this amazing technique, and thank you, Dr. Dellon, for introducing this technique in the world.
Okay, so the aim of selection is to accurately identify patients who will truly benefit from decompression, ensuring timely intervention for those with progressive neuropathy. So the key to successful decompression is appropriate patient selection. Establishing the indication for surgery becomes appropriate in patients who demonstrate persistent symptoms despite adequate antiglycemic therapy with clear clinical or functional deficits. This would be the following groups of patients. That being said, it's equally important to define in what patient groups surgery would be unbeneficial. Those would be patients who have longer standing unregulated diabetes and whose disease has progressed beyond reversibility. These are the following groups of patients. So to select patients appropriately, a certain pathway of clinical and imaging diagnosis tests need to be followed. The first and most important to assessing the diagnosis of focal nerve entrapment would be the Hoffman-Tinel sign. More commonly known as the Tinel sign, it remains one of the most informative bedside tools. A positive Tinel sign at the tarsal tunnel is defined as eliciting radiating paresthesia into the plantar foot, which suggests focal constriction of the tibial nerve. We also note the intensity of the reproduced symptoms using the VAS scale. A positive test alone strongly contributes to surgical decision-making, even more when combined with other findings. Namely, as Dr. Dellon himself published, in diabetic neuropathy, the presence of a positive Tinel sign has a sensitivity of 88%, a specificity of 50%, and a positive predictive value of 88%. Evaluate the impaired tibial nerve function by evaluating the sensory function at the plantar aspect of the foot. Of all neurosensory tests, we chose the 2-point discrimination as a reliable semi-quantitative measure of tibial nerve entrapment. Using the Dellon discriminator, this test is done by substantiating the minimal distance measured in millimeters, at which the patient can feel being poked by 2 points. So we perform it, as you can see in the image, in the medial and lateral plantar distributions and the heel region innervated by the calcaneal nerve. And technically, it's important for this test to be done by one experienced practitioner in all patients in order to minimize variable pressure, administration, and other varying determinants. So when performing this test, practitioners should take their time to communicate with the patients and being precise in explaining the process of testing. Also, to avoid subjectivity, it's recommendable doing the test with fewer attempts to avoid noise and confusion, while making sure to press the disc with constant pressure with the 2 pins at once. 2-point discrimination also provides an excellent baseline for pre- and post-operative comparison. Alongside sensory recovery, it's essential that we evaluate posterior tibial artery blood flow, as the diabetic angiopathy it's an important determinant in developing the potential complications of diabetes, such as diabetic foot ulcers. As Dr. Pejkova explained, the pre- and post-operative comparison of the values of blood flow it is critical, as it provides complementary evidence to sensory testing and helps us quantify the full scope of physiologic improvement following tarsal tunnel decompression. Because diabetic patients represent a significant portion of those with tarsal tunnel syndrome, the Michigan Neuropathy Screening Instrument is a tool that allows us to quantify the degree of systemic neuropathy. It's a self-evaluation symptom questionnaire in which the patients answer questions that describe the most common symptoms associated with diabetic neuropathy. In our experience, it's a very reliable method. When compared pre- and post-operatively, it serves to follow changes of symptoms of neuropathy over time. Another tool of importance is in the preoperative pathway is the foot functional index, which captures the functional impact of pain and disability on the daily living. It measures pain severity when doing everyday functional activity, difficulty with ambulation, and activity limitations. So it serves 2 purposes, determining the preoperative level of disability and providing a robust metric for postoperative functional comparison. The next step refers to the candidates for surgery that have persistent foot ulcers. So this assessment tool, the MIST, its name is the acronym of the 7 critical characteristics of foot ulcers that the tool describes. This tool also serves as a means of monitoring the wound healing process when done pre- and post-operatively. So the decision to operate is not solely based on a single test, but on converging evidence. When patient history, provocative testing, sensory dysfunction, and vascular evaluation and neuropathy scoring systems collectively indicate tibial nerve compression, then decompression surgery is often the logical next step. Importantly, the same evaluations are performed pre- and post-operatively. So objective comparison enhances the transparency of the outcomes and strengthens evidence-based refinement of our surgical criteria. The technique was elaborately explained by Dr. Pejkova, and I would like to give Dr. Dellon the final word. Thank you.
Well, I'm back. And I wanted to show you how we could extend this to some other areas. And just quickly, after I figured out the clinical approach that you've just heard, we went back to the laboratory, and you can measure footprints, as you can see here. If you go to the beach, you can make these measurements of footprints. The critical one for neuropathy is the print length. And we had an animal model, and in this animal model, print length increased. And just to show you, as this would be normal, and as print length increases in animals that were made diabetic, you give them streptozotocin, 60 milligrams intraperitoneally, and a group of them get better, and their blood sugar returns to normal, and their print length returns to normal. And we operate under the microscope and release all the same nerves that Dr. Sofija showed you before. And here, this is a group of animals, normals in white. They had their tarsal tunnels still there, and as they became, they were made diabetic, you can see their print length increases. But in another group of animals where their blood sugar was still 400, but we released their tarsal tunnel at the start, they walked like normal animals for a whole year. This is half the animal's lifetime. And the way you know something is true is if it can be repeated. And this was a repeat study done in the country Turkey that confirmed this. In the United States, this was also confirmed in Maria Simonow's lab at the Cleveland Clinic. And finally, this was confirmed in another group in Romania. So we have 4 separate basic science labs. Dr. Tusheva already showed you this, that the Tinel sign is the most critical thing. This was a question asked the most. And the patients have to be symptomatic. As you heard, they need good glycemic control. If their foot is swollen, we don't operate on them. We give our patients neuropathic pain medication. Usually they need 3 months of this to show they still have their symptoms and haven't responded to drugs. So I would include that. They need to have adequate circulation, as you saw, and then the positive Tinel sign. And here I'll just show you one similar study, again, that shows reversal of progressive disease. We had 50 patients, and here on the right side, you see a foot operated on 3 years before, and the left foot was not operated on. Here you have another patient whose foot was operated on 7 years ago, and the opposite foot was not operated on. And when you looked at the statistics for these two, we showed a very significant difference, meaning the operative foot has a reversal of the progressive. Rehab was not touched on. I just want to show you it's important for the nerve to glide. The patient walks immediately after surgery. And when we walk, we tell them to lift and bend from their knee.
From your knee, that's right. But from your knee, more.
If they bend from their knee, they won't tear apart your ankle incisions. So this also works in people with leprosy. And these are people with leprosy, and you can see their ulcers from the tibial nerve involvement, their amputations, their ulnar nerve compression sites. And although leprosy is thought to be said to be cured by the World Health Organization, the paradox is that what they mean is when you give triple drug therapy, people are no longer infectious. But there's still about 4 million people with progressive neuropathy worldwide, and we can help them with surgery. The Sofija's did not show you the perineal nerve, and I'll just show you briefly. This is in a diabetic, the different color, and that's not a lipoma. That's the diabetic nerve swollen in a diabetic, and the common perineal nerve released at the fibular head. And here in somebody with leprosy is the same nerve. Someone asked whether we do an internal neurolysis, and here we've opened the fascicles. And on the diabetic nerve, if you look through the epineurium and you don't see fascicles, there's intraneural scarring, and we do open the epineurium, and we'll separate, not divide. We separate the tibial nerve from the tibial artery. And I'll show you, here's an example of someone before surgery. You see they could not extend their big toe and they could not extend their ankle. And here in the recovery room, they're extending their ankle and extending their big toe after perineal nerve decompression. And here again is the tickle test in this patient with leprosy. And here's an ulnar nerve at the elbow to show you an upper extremity nerve. You can see this big swelling in the leprous nerve, and here's where it was compressed. So here's a woman who in this side, before surgery, she couldn't do her hair in any other position than this because she couldn't comb her hair. She couldn't really hold her pot well. And after working on her ulnar nerve, you can see better left hand function. And this man, you'll see his clawing is reversing down here, and he has improved hand function. And finally, in chemotherapy-induced neuropathy, and there's so many people with getting platin and cisplatin and Taxol, lung cancer, breast cancer, colon cancer. There's no currently proven treatment to treat this problem. And so we did the same operation you saw in the last thing I did on animals as an experimental study. We gave the same rats, a different group of rats, but we gave rats chemotherapy. And here when we operate, you see their progressive neuropathy developing compared to normal. And then if you stop the drug, some get better. And then here we operate and we can reduce this kind of problem to this kind of problem. And given that, we started doing this in people. And this is really my last slide. And you see the woman on the right side here has had chemotherapy for breast cancer. Is in a wheelchair. And here she is after having both feet operated on, walking on the beach in Hawaii. And I thought you might wonder why we all become surgeons. It isn't because we save so many people's lives. We just love these little green shoes you get to wear in the operating room. And thank you very much. We can answer questions now.
We do have a couple in the chat box. So let me start with some really good questions. So thank you to all the attendees. One, Dr. Dellon, I know you have touched on this previously, was the issue of wound healing. And I think this could be kind of open to everybody, but maybe starting with you, Dr. Dellon, as far as what wound healing issues have you encountered with this patient population?
What Sofia's group has shown is what often happens is surgeons get to care for non-healing wounds in a wound healing clinic. And that's how I started with some patients who did have ulcerations. But in general, there's so many diabetics who don't have ulcerations. And if you can get to the patients without ulcerations first, you can operate on them. You don't have to wait till they get ulcers. I tried to show you in that prospective study. If you operate on people that do not have ulcers, you can have wound healing problems, but the surgery is designed as a straight incision. There are no flaps, no skin is elevated. If you can keep the ankle from doing too much movement, the wounds will not pull apart. So the commonest complication, I would say, is a mild foot infection in the diabetics. And maybe in less than 1 or 2% would you have an actual wound disruption. I've only had 2 wounds that disrupted over all these years. One was by someone who just went right back to work and didn't really care for the wound, even when the sutures were in and the wound opened up. So those are the real problems. I would say that's really the commonest problem we've had, and it's not a common complication if the patients will take care of their wounds after surgery. As Sofija showed you, if the people do not maintain good glycemic control, they can go right back to the same problem they had before.
Excellent, thank you. And Dr. Pejkova, maybe could you let us know, do you tend to do nerve conduction tests before surgery? That's another question from the attendees.
No, we don't need nerve conduction test. Just as my colleague show our way of selecting patient. There is a TNL sign, 2-point discrimination, and with it was interesting case. Now we've operated two weeks ago. We have a patient with diabetic foot ulcer, and she goes through all this evaluation protocol. And she has on her right feet diabetic foot ulcer, but the diabetic neuropathy symptoms were more amplified on the foot without ulcer. And we made a Doppler ultrasonography, and the signals of Doppler were worse on the feet without ulcer. And I told her, we should operate your other foot, not the foot with ulcer. No, doctor, please, I like to have operation on my feet with ulcer. And we do that. But after a few days, when he came on the checkup, she was honest and she told me that actually she has a bigger problem with the other with the other leg. So she will be candidate for operation. But so the very precise evaluation of the patients. We don't need electroconduction studies. We don't need MRIs. We just need this pathway, and we have right patient.
Excellent. Thank you. Yeah.
I had the tiniest note to that. In the United States, the American Diabetes Association says every diabetic should have, with symptoms of neuropathy, should have an electrical test once a year. And that test shows that they have problems with every nerve they test in the lower extremity. They really can't show superimposed nerve compressions because the function of the nerves is already so poor, they technically can't show superimposed nerve compressions. And about 50% of normal people have abnormal EMGs in their foot intrinsic muscles. So the electrical test is useful to prove that the people don't have a lumbosacral disc, to show that many nerves are not working, but they cannot really show superimposed nerve compressions. And that's the value of the Tinel sign for showing in that location you have a nerve compression.
Excellent. Thank you. Dr. Tusheva, you had kind of talked through the workup of patients and identifying patients. We had a question about the HbA1c test and whether one is sufficient or do you do 2 to 3 tests over a period of time?
So preoperatively, I would say only one measurement is sufficient because it's an average value of the past 3 months of glycemia values. So that means that for the proximal past 3 months, the blood glucose has been stable enough to have an adequate wound healing after the surgery. So that's the whole point of the hemoglobin A1c measurement before surgery. Is that hope that answers the participant's question.
Yeah, thank you. We had a couple more questions if everybody still has a few minutes for the speakers to stay on. Okay, excellent. Dr. Pejkova, when evaluating diabetic patients, how do you integrate the decompression into your overall management algorithm? So in which clinical scenarios do you believe decompression should be considered alongside or even before traditional approaches such as offloading, vascular optimization, and glycemic control?
The patients, all the patients are with, as you see in our cohort, with long-standing diabetes, and they have a history of diabetes more than 3 years, 2 years, 4 years. But we should think about the patients who has diabetes, that they could develop diabetic neuropathy. So if there is not checkups from us, but from the general practitioners on this is Tinel sign, Michigan neuropathy score. They are really easy questionnaire, and they can pick up right patients on right time without ulcers to be operated on, and we can prevent development of the ulcers, and we have a right patients in right time. That is very important according to me, because we have to put awareness not only on the surgical community, but to the general practitioner, to our colleagues who are dealing with patients with diabetes.
Excellent, thank you. Dr. Dellon, is there a way of identifying nerves that would not benefit from decompression? So, for example, you touched on the no-Tenel with obvious muscle wasting as one possible example.
So first, I'd like to say that we decompress more than just the tarsal tunnel. I tried to show you the common perineal nerve. We try to work on nerves to the top and the bottom of the foot at surgery. And I don't know if that was really clear. We decompress both the perineal and the tibial nerves at the same surgery. So the statistics are that if they have a negative Tenel sign, well, what happens is really when a nerve is compressed, early on, there's no Tenel sign. There's just numbness and tingling as the nerve becomes hypoxic. And then once a nerve in the experimental model, both in rats and in monkeys, and then you can extrapolate that to us upper level primates, once the nerve has been compressed for 6 months, it demyelinates. That's when the Tenel sign starts. So in the earliest compression, there's no Tenel sign. Then there's a Tenel sign for this entire cycle as the nerve, the myelin degenerates, and then the axons die, beginning at about a year of compression. In the experimental model, the axons die. When the axons die, there's again a positive Tenel sign. But you can imagine that after 2 or 3 years of the axon dying, there's no more Schwann cell sprouting and there's no more axon regenerating, and the Tenel sign goes away again. So when you get somebody with diabetes and an ulcer or loss of sensation and severe symptoms, but no Tenel sign, it doesn't mean there's no pressure on the nerve. It just means there's nothing there alive enough to regenerate. And so in order to find out the answer, we did operate on people like that, and our success rate was only 28%. That's within the limit of a placebo effect. So for people with severe pain and a negative Tenel sign, we tell them they have very little chance of really getting sensation back, but we may be able to relieve their pain if we decompress the nerve. So that a negative Tenel sign means you have a very small chance of success. In people with severe pain, we can promise them a chance for pain relief by decompression, but not recovery of sensibility. And we do that for each of the nerves. So you'll do it at the tibial nerve at the tarsal tunnel, the perineal nerve at the fibular head, the deep perineal nerve over the dorsum of the foot. Sometimes the superficial perineal nerve needs to be released in the lateral and anterior compartment. So you just examine each nerve, and if there's a negative Tenel sign, and then we haven't had time today, but just like in the upper extremity, you can have a pronator syndrome where the median nerve is compressed in the proximal forearm. You can have compression of the tibial nerve in the popliteal fossa, the soleal sling. And so there's a proximal site of tibial nerve compression. And some people may need both the proximal and distal sites compressed. Now that's very advanced thinking, but in some people in whom a tibial nerve decompression may not be helpful and there's a negative sign there, the patient may be very tender in the tibial nerve behind their knee. And you might try decompressing them there and let the nerve regenerate from there to the ankle. And then 3 months or 6 months later, decompress further distally.
So we had maybe just last 2 quick questions, and thanks everybody for staying on with us. But going or continuing on that point of decompression sites, we had the question of, is there a role for the release of the tibial nerve at the soleus arch?
Yeah, that's what I just said.
Okay, thank you for that one. And then the seral aponeurose does seral aponeurose decompression is it useful? If yes, in which patients?
The sural nerve?
Yes.
Okay. The truth is there's no known site for compression of the sural nerve in a normal person, but the sural nerve does go from in the popliteal fossa to the skin, and at some point it goes through the fascia. And if there are people who have the regular decompressions and then remain numb on the outside of their ankle, as I just mentioned, you need to check the superficial perineal nerve and tap along the sural nerve, and you may be able to locate a site for compression of the sural nerve on your physical examination, or utilizing ultrasound along the course of the sural nerve, you may find where it goes from being thin to being relatively fat at the site of compression. So it can happen, but there's no known common site for the sural nerve to be compressed.
Excellent. Okay, well, thank you, everyone. I know we have run over today, but really appreciate everybody staying on with us and attending today. A huge thank you to our speakers, Dr. Pejkova, Dr. Tusheva, and Dr. Dellon for taking the time to put together these presentations, share the outstanding information with us. Because there was so much covered, this will definitely be put on YouTube so folks can go back and rewatch any section. We hope to see you in January. And until then, I hope everybody has a great rest of the year. Thank you so much.
Thank you, Steve. Thank you, Sofija and Sofija, for your excellent presentations.
Thanks,
Thank you,
everyone.
Dr. Dellon. Thank you,
Thank
Dr. Dellon, for your
you.
inspiration and for guiding us whole time.
Thanks, everyone.
Thank you.
Bye.